Good day, everyone. Thank you for joining this practical session, the second session dedicated to the use of a Swiss DuoClast. My name is Mary-Christine Colette. I'm an education specialist working at EMS Electromedical Systems in Switzerland. And I'm in charge of coordinating training programs worldwide with the Swiss DuoClast Academy and GDT, Guided DuoClast Therapy. So today we'll be doing a practical session, and we have a pleasure to welcome again our Swiss DuoClast expert, Dr. Peter Stiller. Good day. Good morning, Peter. Thank you for being with us. So just a short introduction about Peter Stiller. So Peter, he's a doctor specialized in sports medicine. He's also specialized in emergency medicine. And he will be providing you today's expertise in his daily practice with the use of Swiss DuoClast on different indications that he encountered with various patients. Before starting this webinar, I have just a reminder on the technical side. So as you can see on your screen, you have a Q&A and chat icons. Please feel free to use them to ask your questions, and we'll be able to answer them during this webinar. So this was the introduction. Thank you again for your participation, and Peter, off you go.
Okay, thank you, MC. Welcome to all participants. I'm pleased to see how many come in. It's really great to see that so many people are interested in what we are doing with the DuoClast, and I want to show you a lot of cases today that I think are very interesting for people who are motivated to learn new things. And we'll start right now. I start with a little conclusion of the last time. This is not very important. Just to say and to have in your mind what is important by using shockwave therapy. It's what you want to reach, or what the shockwave does is it reduces the sensation of the pain. It's very important for all patients to be in a good mood. If you start a treatment and you know it needs weeks and weeks to get it better, then it's very hard to have a good compliancy. And now with this kind of treatment, it's much more easy. The blockade of the neurogenic inflammation is very, very important, because this is opening the door for all that you want to do. The activation of the stem cells, the release of the growth factors is very important, that you block the inflammation before that, to let them work as good as they can, the stem cells and the growth factors. And the improving of the blood circulation is one more very important point. So we come to the conclusion that what we want to reach with the DuoClast and the shockwave therapy. We want less medication. We want less or no injections, especially no cortisone. We want fewer operations. We are non-invasive. That's very, very important, and very important for a lot of patients. We are less risky, of course, and it's very, very high effective. I would say about 90 to 95% of our patients get better. I would more say 95 than 90. And you know, happy patient is successful practice, of course. You all know from the last time the typical indications. I don't have to bring them again. You will see the lower limb today. Some of them are also in there, but a lot of them are more from this, or even from this file. We are doing a lot of things that are not really indications that are well known. So we call them off-label, of course, but I think these are much more interesting for guys like you to see what is possible with the shockwave therapy. And what I bring always in my webinars is the best sentence, the best speech that I ever heard about the shockwave. It's from a football legend from England. It's pain is temporary, glory is forever. At the beginning, you have a little pain by using the shockwave, but what you do to the patient, what you bring them for more life quality, is the glory that stands for everything. So let's start with the case studies. The first is a very, very extraordinary case, because this is a young woman now at the age of 27 that I know from her since her 11th birthday. She came in the children's hospital in Augsburg, where when I was a very little assistant doctor, and she was suffering from osteomyelitis after, I have to go back, sorry, from osteomyelitis and osteonecrosis for the last 16 years now. I know her the whole time through, and we started to use Shockwave for her, I think in 2017. Yeah, that's right. And before that, I show you what happened to this girl. You see the legs here, you see the holes, you see the bone marrow edema. Here is you can see the steps from 2011, 2014. It's always a lot of bone marrow edema. You see that the joint there's no smooth joint surface. There's a lot of friction when she's moving. You see the osteonecrosis in the pictures. Here it is her left foot. You see that there's always a swelling. She was always on sticks at the age of 13, 17, here at 23. It was a terrible time for her. Always, you can see here the swelling of the left and several times operated foot. Not a good time for her. She had about 10 operations at only this leg. And the MRI that I want to show you, I don't have the MRI, I have just the text for it, was in 2016 when it got very, very bad. She had, again, osteochondral lesions. She had clear bone marrow edemas, very confused in the whole bone, and a new inflammatory process, so that she was put into a plaster for 7 weeks. We're not allowed to step on the foot. So absolutely a break in everything for her. She was really lying in the bed and waiting for 7 weeks to get this new inflammation better. The problem was that after 7 weeks, some inflammation was better, but she had more osteonecrosis. She had a new cartilage damage. She had minor bone marrow edema, but not gone, and she had new bone marrow edemas without any load on the foot. So it was a terrible situation for her. As you can see here, for example, and here, this is a completely new bone marrow edema without having pressure on the foot. So that stands for unbelievable inflammation going on in the bone and the whole joint. And now the situation was so bad that she had severe pain all the time, swelling all the time. She was completely unstable in her ankle. That's why she was using the sticks all the time. She couldn't do any sport, of course. She had 2 university courses, quit it because it was not possible to stand on her foot, so she couldn't go to the courses. She had a completed kindergarten teacher training, but she couldn't work because she couldn't put load on her foot. So that was really a bad time. And then there were 5 specialized surgeons for ankle surgery, and they all told her that she only had the possibility to stiffening the ankle joint or amputation. The last 3 very well-known specialists said, okay, don't think about the stiffening. It's only a matter of time, and then the amputation comes. In every case, you can't do anything against it. Do the amputation at once now, and then your life will be better. I think 2016, she was 22 or 23, to tell somebody that there's only the possibility of an amputation is really, really a hard thing. So she came to me crying and said, this is only the last thing that I can do, and I will do the amputation. I said, okay, let us do another thing. We have a lot of scar tissue in that ankle. That's why you cannot move it really. And let's try to get all the scar tissue out of this, all the little parts of the cartilage out of this with a surgery. And after that, we work on your ankle with Shockwave, and then we will see. It's the last chance that we have, and then you can do the amputation if it doesn't work. We found someone at the Schön Clinic in Munich, Munich-Harlaching. It's a very well-known clinic for foot surgery, and he did a very great job. He really, you see here in the arthroscopy, he did exactly what I wanted. And after that, we started, and that's very important for you. We started on day 4 after this operation with a full therapy of 1 to 2 treatments per week with Shockwave, and the result was that it was significantly less pain than in all the times after operation before. The swelling was nearly gone after 2 weeks. 2 weeks. We are talking about 2 weeks after this operation. Means we had 10 days of treatment. The mobility improved much easier and much faster. And with the help of the crutches, the patient could put weight on it much sooner than before, and sooner than the operator, the surgeon told us. And after 4 months, we had this result. I'll show you the pictures. I think this is enough. If you see this bone here and the bone you saw before in the pictures, there's no edema anymore. There is no big hole in the surface of the joint. This was one of the most impressive things that I've ever seen before, because absolutely nobody were thinking about this result. And if we go back, you see here, I put it here in words, no signs of inflammation in the bone, osteonecrosis slightly reduced, no swelling anymore. She could go to the gym, started studying again. It was a really great result. This is the last report of the radiologist here. Healed osteochondral lesions of the distal tibia. I think that was for, especially because we are talking about osteomyelitis. It's an all including inflammation in that part, and you saw what happened to the bone and the whole joint with just having 7 weeks of absolutely doing nothing, and it got worse, not better. And now we worked on it after this operation, and you see a perfect result. That's the girl. This is from 2018. She's a big fan of the country of Iceland, and that was the first time that she was able to visit this country in 2018, because now she could step on her foot. And this photo she sent it to me 1 hour after a 5-kilometer walk over all these stones here in the back. And she wanted to show that this is possible now. And the next one is from 2021, the next visit to Iceland. And you see she did the photo every day after every big journey that she did. And that's really great to see how many life quality you can bring back to the people with this treatment. Another thing is, I didn't talk about it the last time with the upper limbs, because I knew that there's this case for you this time. Wound healing. This is for me very important, because you can do unbelievable things for wound healing. This is a friend of mine, really a 41-year-old, but very fit and athletic patient. He's doing marathon and playing football, and he fell off a ladder of 2 meters high. He landed on his foot. It didn't happen anything, but there was a metal standing out of the ladder, and it cut his thigh, as you see here, very, very deeply. It was a severe soft tissue injury, skin, fatty tissue, fascia, and muscle. And he was very lucky that it didn't touch the vessel here, because then it would be very, very dangerous for him. He got surgery at our big hospital here in Augsburg from a very, very, very good surgeon. He's the chief of the surgeon, what do you call it, level here at the head of the trauma surgery. So that's what I wanted to say. Professor Meyer, well known by you in the whole Germany, and he did a good job, I think. But the problem was there got a big inflammation in this wound. You see it here, how it worked, and the necrosis. And that was the end, when they said, okay, now we have no chance anymore. We have to do another operation. You see here the yellow of the inflammation coming out here. Here's the necrosis zone, really not looking very good. And you see the red signs outside here. You see the swelling, and it was very, very painful. And now what they were supposed to do, of course, they said debride the wound, leave it open, rinse it and wait. And after that, when the inflammation has gone, and of course antibiotics and so on, and after that we do a muscle flap transposition, and after that a skin graft. So he had to have at least 2, 3, or even 4 operations. The total healing time, they said, is 6 to 12 months. Keep that in mind, please, for the next files. And depending of the speed and the level that and the progress of the healing, it would be possible to do sport or not. And that was for him terrible, because, as I said, sport is his life. And then he came, and I've never seen him crying before. And when he came and told me that he was crying, that what we can do, that he can do his sport afterwards. And I said, okay, we have another possibility. Maybe we had in the background the possibility to send him to the hospital, and they would have operated him how do you call it? Whatever, at the moment he comes in, so he wouldn't have to have waiting time, and that's, for me, that is perfect, because I can start a therapy. If I see that it doesn't work, I can send him to the hospital. But in this case, we started with 2 different antibiotics and shockwave therapy, of course, and I had to put away the necrosis 2 times, but I've for more than 4 years of surgery in the years before, so this was no problem. But now I show you what happened after 8 weeks. Okay, 8 weeks. We had from the surgeon, we heard 6 to 12 months. He has to wait for the healing. Now 8 weeks and 10 treatments later. This is a video. This is a video in German. I tell you afterwards a little bit, but I want to have your eyes on the scar and on the tissue around it. Handelt sich eine schwere Rissverletzung. Ende September ist es abgeschlossen. I have to stop it. You can't hear me otherwise. What I want to show you here is the scar is perfectly closed. That's not the problem. The problem is normally the tissue around it, but the tissue here is a normal muscle. At this time, he has been on running for 3 times last week. 3 times 8 kilometers without any problems after 7 to 8 weeks, and this is the soft feeling of the muscle is perfectly normal. If you see how many pressure I put on this tissue, you can see that it cannot be any hardening or any bad healing under it, because he would have cried of the pain. And here's absolutely no pain. We are working with 2.8, 2.9, maybe more than 3 bar, and he has no problem. Okay. The next case.
Peter, I have a question concerning wound healing. Could castor oil be applied
Castor oil?
to help healing the tissue, or?
What do you mean by castor oil?
Castor oil. It's the oil that is regularly used in scientific studies to help the tissue. It's very thick,
Okay. Yes, I think we did kind of plaster, of course, on it. You have to do that, of course. But this is not what you always do. Like you have something with silver, for example, not to have any bacteria in it and so on. That's what we do. Of course, we don't leave it open. Of course, we do the treatment, then we put all the stuff on it to keep all bacteria away. And then it heals under that. And then the necrosis comes up very fast. After the first treatment, I could do the first necrosis section, necrosectomy, it's called, I think, to put it away. And after the fourth session, we did the rest of the necrosectomy. So there was, after 4 treatments, there was no necrosis anymore. And then it healed like, it was unbelievable fast.
Yeah, it looks like.
We always did the plaster between the treatments, of course. It has to be covered, of course.
Okay, perfect. Thank you.
The next case is also very impressive because this was a guy suffering from an osteochondrosarcoma, very malignant in the right knee and in his lower abdomen on the right side. That's not right, the upper abdomen, it was the lower abdomen. And because of this locations, the right foot or his right leg had an unbelievable swelling. I'll show you the picture right here. You see it in the comparison to the other side. It was unbelievable. We had here it is said 47 centimeters at the knee of the circumference. You cannot imagine what that means. He had 56 centimeters at the lower leg and 31 centimeters at the middle foot. If you try to do this, you have to use a lot of plaster to get it sick like this. And in this case, we have a very thin other leg. So if you compare, it's unbelievable. And at this moment, he had 4 times a week a lymphatic drainage of 90 minutes to keep this 74 centimeters. Unbelievable, really. And they told him that he has to have an amputation at the thigh, and he said, no, if you have no solution for the tumor in my stomach, in my lower abdomen, I will not have the amputation. And they had no answer, so the leg was kept. And you see the next picture, and he had radiation, of course, at this area of the tumor, and that was the end of the result of the radiation. That the skin was opened up. He had wounds and very, very hard skin. It was really terrible. And then when he came to me in 2017, we had this fibrosis and induration of the skin. We had this grotesque swelling. Here it is again, 56, 74, and 31 centimeters circumference is unbelievable. Constant pain, restriction of movement. Of course, you cannot move such a leg. There was 20 degrees of the knee flexion still there. The tibial nerve was damaged. And of course, he couldn't sleep anymore, and he had a severe psychological impact. But the good thing was that he said, you can do whatever you want. Nothing helped me before, so try whatever you want. So we tried, and I know from a lot of treatments before that the lymphatic drainage is unbelievable with the DuoClast, and we started. That's a lot of work because with such a leg you are working about 20 to 25 minutes. And you're always doing it like a normal lymph drainage, always from distal to proximal. And we started like this. And after three treatments, he said he has the feeling that he gets better. He has the feeling that he can move his ankle much better. The Achilles tendon, it was not so painful anymore, and we could go up to 2.2 bar, which is much in such a swollen tissue. After 5 treatments, his physiotherapist asked him what he's doing at the moment, because they couldn't do the lymphatic drainage with their hands so easy before. And it was also funny because he had 6 hours of sleep from this 5th treatment on. Before that, he had for the last month, he had only 2 hours in a row, and now he had 6 hours, which was very, very important for him for his life quality. Then after 15 treatments, he can stand on his toes with this leg. And after a lot of time later, you see 7 months later, we had a big surprise because he was on a how do you call that? He's selling kitchens and things like that, and he's always on he has to go on meetings to tell people about his kitchens, and there he has to stand a lot of time. And after I think a 5 or 6 hours standing, he recognized that the foot or the leg was swollen again a little bit more than normal. And then he went for a walk, and after the walk, the swelling was gone. So his muscle pumps worked again after month and month without any muscle pump and lymphatic drainage on his own. He had his lymphatic drainage back. And now at the moment, we are not really often working on his leg every 8 or 10 weeks. That's pretty enough because he's walking about 1 hour every day, and that's enough to get all the swelling away. And I show you what is the result today. If you compare that to that, from 74 centimeters to now 44, this is very, 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 very interesting. Very, very impressive, I think. And the question that always comes up is, of course, what did the tumor? They told him if you start the shockwave on the tumor will spread away, and we will have a lot of more metastasis. How do you call it? Metastasis? Yeah. And the problem for me was not the patient. The problem were the other doctors, because the patient said, doesn't matter. They told me that it will kill me in a few months. My leg is as big as you only can amputate it. So it doesn't matter what happens with the shockwave. The most important thing is to get my whole leg better from the swelling. And then we did an MRI after a month and month later, and the new tumor was 2 centimeters smaller. I don't say that shockwave is good to get the osteochondroma or osteochondrosarcoma smaller. That's, my God, I would never say that. But we didn't do any harm to him. It didn't spread. It didn't get bigger or something like that. Nothing. And so I think the result was great for him. It was a lot of life quality that he got back. This is for me, very important, because I see it more and more often. Is osteochondrosis dissecans, means a little flap or lag in the cartilage. For example, here at the talus bone in the ankle joint. That's one of the most most well-known places where it comes up. And this is a lady who had an operation on the other ankle because of osteochondrosis dissecans. It didn't get better at all by the surgery. That's pretty normal. I have a lot of patients that are coming to me because surgery didn't bring them any benefit. This is from the August 2016, and then this is May 16 before the treatment. You see it here. This is August 16, where he had the result 2 files before. This is also still before the treatment. Here you can see that the bone marrow edema is getting more and more deeply. And what we did is, what we do every time with these cases, we use the radial and focused, in this case, combine both radial and focused shockwave. We give them vitamin D, of course. They get cooling bandages for the pain, and something else like omega-3 fat acids for working against the inflammation. Beetroot is the same, it's working against the inflammation. And we had her pain-free. She couldn't walk properly when she came. We had her pain-free after 4 weeks. The frequency of the treatment could be reduced after this 4 weeks from once a week to once a month. At the moment, we treat her every 6 to 8 weeks. But then it was very impressive, because we got a better result 3 months later. You see it here. The result is much better, and not the bone marrow edema is getting less and less. But the most important for me is 3.5 years later. Right, there's the improving as the result of the radiologist, and 3.5 years later, she went without telling me to the next MRI. And that was the result of the last MRI. And as you can see, the radiologist called it a consolidation of the osteochondral defect. I think in the literature, you will not find as many cases where an osteochondrosis dissecans is completely healed. without any treatment like surgery with cartilage transposition. And even the operated patients don't have, if you don't have so many operated patients where it worked, I think it's less than 10% where it works like this. And here we have really a healing of the osteochondral defect. That's why I showed you this case. There are a lot of these cases, but this one is great because it was her idea to go into the MRI 3.5 years later to have a look what happened. And the funny thing is, in the last 3 months, I had 3 more guys after 1.5 to 3 years where they have the same result. And that's very impressive for such a kind of diagnosis. The safest disease is the so-called apophysitis calcanei. It's always a problem for children. They suddenly get pain in their calcaneus. It's very painful for them. They cannot step on it. Here it is a 7-year-old girl had sudden pain in her calcaneus, in her heel. She had no trauma. That's pretty normal for children. She was unable to roll the foot, so she was always stepping on the ball or on the toes. The X-ray is always unremarkable. Sometimes you have, if you do an MRI on children, if you do an MRI, you see a bone marrow edema, but nobody can tell you where it comes from, and nobody can tell you what to do. And what they always do, my colleagues all put them into a plaster, immobilize the children. It's terrible. Never do that with children with such a disease, because the immobilization is very, very bad as well for the bone and for the head of the children. We work with very low pressure on these children after telling the patients, of course, his parents, of course. The parents must be well educated what we are doing on their children, because they have to underwrite it and give us the possibility to start. If you tell them that you work pain-free, then it's much easier because they all know normally that Shockwave is a painful treatment. In this case, you don't have to work with pain. You're nearly no pain. You just try it with the lowest level of pressure that you can put on, and you have the best device that you can have, because the DuoClast you can put nearly to 0.3, sometimes 0.2 bar. That's pretty perfect for this. And then you start rising up until the child says, now there's a little pain. Then you go back on the level where there's no pain, and then you use, of course, only the radial shockwave. Never focus. It's not possible, not necessary at all. The improvement comes normally after 2, latest time after 3 treatments. And in this case, you see after 4 treatments, she was completely pain-free, and we could use 1.3 bar on the heel of a 7-year-old girl. But the problem was, after that, everything was great, but then the other side was also affected. And what we did, of course, and the girl knew the treatment, so she said, okay, let's do the other side. That's what we did. Let's do it all again. Same procedure, starting with 0.5 bar, finally 1.5 bar. After 4 treatments, everything was gone. End of the story. She didn't came back the last 3 years, and she's very sporty. So now we changed a little bit. These were, I would say, normal patients. Now we changed to treating athletes, not only professional athletes, but athletes, because a lot of things that we treat come from sport, are affected by sport. And that's why I put it in 2 groups. Now, here come the athletes. You see, had a few times I had a possibility to treat athletes. And I want to start with this sentence. I think this is great. Football and the Olympics are the modern forms of war. So now you know why all of these guys get an injury in the time they do their sport. And then another problem when you're working with professional football players, for example, is that they are not always the, I would say, most intelligent people in the world. So it is not so easy to get their compliance, but you will see if you use Shockwave with DuoClast, it is much easier to get compliance because you have so good and so fast results. This is not against Franz Beckenbauer. It's a funny sentence that he said, but we have a lot of football players that are not really says things like this and mean it. Okay, using it in sport means we use it in muscle injuries, tendon injuries, muscle tensions. That's very important because you can avoid muscle injuries if you work very early with muscle tensions. Ligament injuries, of course, intersopathies, as well known bone edema and fractures. Only to show you how important the DuoClast could or can be in working with athletes is here you see the suffering time. That's important. The suffering time means how long couldn't they do their sport, be back on the field to play football in the season of 2017 and 18, only by muscle injuries, tendon injuries, as you see it here. And these are 79% of all days off for injury in the German Bundesliga, the highest class in Germany. And all of these can be treated by Shockwave and much easier and much faster than if you do it only with the physiotherapy. So I want to start with one of the most most common injuries in football that we have, not only in Germany, but in the world. It's the ATFL rupture. It's an acute rupture that we start to treat at once. When they happen, they come in and we start with treatment. That's very important. The first that we do, this was a German football player from Augsburg, the team I was the team doctor at this time. We did an ultrasound. We saw the complete rupture. We saw massive ankle joint swelling. And in this case, we start always with a high power laser and a cooling therapy. It's mostly a hyperbaric CO2 cooling therapy. It's very, very fast. And then a cooling compression bandage after 12 hours. This is what we do at the first 12 hours. After 12 hours, we start again with the laser, but also we start with the radial shockwave. If you tell that the people normally after 12 hours we start radial shockwaves, they all say you are absolutely not normal by treating after 12 hours. But this is possible if you treat like this before, the swelling is gone, the pain is gone a little bit, and then you can start radial shockwave. And after doing radial shockwave, 12 hours later, normally the swelling is gone. It's unbelievable how fast it is, but it's really very easy for the athlete to put load on the foot again, and there's no swelling anymore, so it's much easier. In this case, we got an MRI 1.5 days later, and there was still, of course, the complete ATFL rupture that I saw with my ultrasound. But, and that is very important, we had a big joint swelling at the beginning when we did the first ultrasound next to the field. But after 1.5 days with this treatment, there was only a very slight swelling of the joint. That's what the radiologist said 1.5 days later. And if you see how we went on, it's just in this case, it's daily radial shockwave. You don't have to do that if it's not a professional player, you don't have to do that every day, but we do it because we have the possibility. Of course, cryocompression, they've got enzymes and fat acids against all the edema and the inflammation that happens in the tissue. Vitamin D, of course, for the next weeks. Stability exercises start very, very early, maybe after 3 or 4 days if there's still no pain. And then we do a fast increase of the load, always taped, of course, so that they have a kind of are safe in their tape. And the RTC, the return to competition, was in this case and in most of the other cases 19 days. Then they are back on the field with full load and full playing in the game. Another thing that comes up very often here is an older sportsman. He's 46 years old, but a former very good football player in the 3rd league in Germany. Now he was or is a marathon runner. He stopped playing football years ago because he wanted to he had persistent knee pain in his I think the right knee when he was playing football. So he started only running and did his marathon again, but then he was stopped, or he had to stop running too because the pain got more and more. And then after he had an MRI after 3 months, there was a clear picture of a severe patella-tib syndrome. All he did before the medications against the inflammation, he had local cortisone injections, which was for me terrible. Physio, X-ray, irradiation means against the inflammation in the bone, and he had pain acupuncture. Nothing worked. Only for a short time he had improvements, but he couldn't go on the training, and the visual analog scale showed a normal pain in his everyday life between 3 and 4, and during training, that's why he stopped all the training between 8 and 9, which is really much. Then we started with the treatment on day 0 was the first start. After 5 days, the second. After 11 days, the third treatment. And the result after 3 treatments was completely pain-free in his everyday life. Started running again, and after 5 treatments, he was completely pain-free in a 90-minute run. And after 7 sessions, we stopped the treatment because he was really healed. There was no problem anymore. What I want to show you here is how we do this. We always aim, of course, on the most painful point at the apex of the patella, but I also work on the whole knee to see if there's any other painful point or any at the tendons, any point where it came to a very bad load, because normally they don't walk or run in a normal position when they have pain, and so you get all the other points around it, like muscle hardening and so on. You have to work on them too. You can also use the big applicator. You don't have to use always the small applicator, but in this case, it was better to reach the point easier. And for me, I always work with 20 hertz, the highest frequency possible, because with the DuoClast, it doesn't matter at all. I told you last time, if you work with 15 or 20 hertz, but you are faster when you, and I don't have to lose time. I think you don't have to too. Okay. This is a very new case from this year, and very interesting because this is a ice hockey goalkeeper from German second league here. He was suffering from a partial rupture of the left medial collateral ligament. You can imagine if the medial collateral ligament is injured for a goalkeeper in ice hockey, it's the big problem. He always has to go with his knees like this. I'm sure you have seen this movement of going with the knees to the ground, not to get the puck through his legs. And if you have in this part here the collateral ligament ruptured or partially ruptured, the problem is you always have to go into the rupture. It's a terrible injury for someone who's doing sport like this. And in February, after conservative treatment, it was better. In February, he had a complete rupture of the same collateral ligament, and all of the guys that saw him before said, okay, they are nearly sure that this is the end of his career, because you cannot do this movement properly and so many times. We have no possibility without an operation, but with the operation, we are not sure if you're possible to do that again. He didn't want to have an operation because he's very afraid of operations, and he had 2 other operations that didn't work in other parts, that didn't work as good as he wanted. So he said, no, no surgery. The surgery was already planned, but he didn't want to. And then he came to me and asked if there is a treatment that we can do before the planned surgery, just as a try. And I said, of course we can do, because I know that you can heal ligaments like tendons, for example, with the DuoClast. And we started at the 7th of April with 2.0 bar. That is great. If you can start with 2.0 bar on a collateral ligament rupture, it's perfect. And we did the treatments every 3 to 5 days. And then after the first 8 treatments, we went on once a week. And the strength and stability training we started at the 27th of April, means 20 days, 3 weeks later, he was allowed to go into the first training sessions. In May, he had no complaints during his exercises. In June, the knee was perfect. An entire training load that is required for hockey goalkeepers, means everything that he normally does like this was possible, no issues. And in September, then we had a muscle fiber rupture in the abductor on the same side, severe myeloglosis and real problems again in the knee, of course. Then we did laser and shockwave therapy again for, as you see it here, 15 days. And 15 days later, there were no more problem with his muscle, no more problem with his knee. And since that day, he is in every, the first goalie of his team in every game they had. I think now they had 12 matches and no problems anymore. And that is really impressive because, as I said, for someone doing this movement all the time, every time in every match about 20, 30 times, it is very impressive to see that this collateral ligament has no problem anymore. Sorry, this is double. Now, another for me, very important diagnosis is the inflammation of the pubic bone, the osteitis pubis. Here we have a professional tennis player. He was 18 years old when he came up to me. The pain was terrible when he came. He had stopped his training for 7 weeks. He had to stop he's a really good, really good professional tennis player. He had to stop the tournament in Wimbledon, and he had to cancel the US Open because of this pain. And after 7 weeks out of training and out of doing anything, just physiotherapy, the problem was that the MRI showed more, not less, but more bone marrow edema, and you see it here, enthesiopathies with a lot of fluid in the tendon. And that was really terrible for him because he couldn't do anything, couldn't walk properly when he came up. Here you see the pain has become even more pronounced over the past 7 weeks. Physio pain medication, cooling, ultrasound therapy, and osteopathy didn't work at all. And that was funny because his osteopath, I think you have the same, they are working like physiotherapists, but more on chiropractic and so on. And he sent, who was involved, sent this player to me for Shockwave because she was on another webinar that I did and had the question if this is possible a few months before. And then she sent him to me, and I told him that we can do something against it. For him it was very important because the doctor that he had from the German Tennis Association, the highest doctor they have, he told him that if you put Shockwave on this bone, the bone will break and that's the end of your career. That's really, it's unbelievable what I would say nonsense is told by people who are not involved in Shockwave and have no idea of what we can do. But this was a sentence that shocked, of course, the patient and his parents. But then I had to explain and show them how we work and that there's no problem for the bone at all. Then I was allowed to start. And now you see, we did it. The first treatment was 1.3 bar. That's okay. It's not so much, but it's okay on such a painful bone with such an bone marrow edema. After 3 days, every 3 days we treated him, and the physiotherapy went on every second day, and chiropractic I did on my own, and also the high energy laser and cryolite. This is the hyperbaric CO2 cooling therapy just to get the pain away. And this was the result. You see, okay, wait, where's the time? That was 7-8 weeks before. Exactly. And after 7 weeks, this is 7 weeks, and the MRI check was after 8 weeks. After 7 weeks, he was in full load in his tennis training, 90 minutes without any problem, and we had a 3.6 bar on the pubic bone at the last treatment after this week. And then we had the MRI check 8 weeks later, and now this is important. You see that we have the bone marrow edema is still there, but it's much smaller, of course. And now you see a kind of secondary cleft sign. This is, in this case, this means an improvement. It's very important. This is not getting worse, but it's getting better. The secondary cleft sign was important because the radiologist was a professor who did his professor work on the bone marrow edema of the pubic bone, and he called me and said, please don't see this as a worsening sign. It is a sign of an improvement, because now you can see the secondary cleft. It was there before, but because of this big bone marrow edema and all the inflammation around, you couldn't see the secondary cleft sign. And in this case, the secondary cleft means, okay, all the other inflammation is going away now very fast, and that's why we see the secondary cleft. And he told me, go on, whatever you did on this guy, go on, it's perfect treatment. That's what the radiologist said. And 2 weeks after that, the guy started with this first men's ATP Challenger tournament and got his first ranking points for the men. How do you call that? For the world tournament ranking, and now he's ranked 400 in the world, I think. This is another case, a German professional football player. And you see here the bone marrow edema. We did I put this very short because we treated him. He had a resistant osteitis pubis, 8 weeks treatment, and nothing improved. The MRI said here, as you see it here, that there is an avulsion, means that here the bone is going away from at the bone where the tendon gets away from the other bone, which is the second step after big bone marrow edema and osteitis pubis. And we started radial shockwave every 4th day with 20 hertz. The amount of impulses is only depending on the pain of the patient. When the pain is getting better, you get to the next step and the next area, and so you go on. And after you have a whole better feeling in the complete area, then you can stop it. After 5 treatments, he was completely pain-free, and he started running and stretching and so on. And the MRI after 4 weeks showed that it was much better. You see the bone marrow edema is gone. There's no more inflammation in the tendons of spring. And after 6 weeks, we had returned to sport, and after 8 weeks, returned to competition. I think 8 weeks is great time to have him back on the field. We have a lot of examples in Germany where they work without Shockwave or with other Shockwave devices. They all come back after 5 to 6 months. So I think we were much faster. This is also a very new case and very impressive, because this is a 15-year-old track and field athlete, very well known here in Bavaria, where I am, because he's one of the best in Germany in his age, and top athlete in South Germany and Germany. He had a very quick shooting pain during his hurdles 1 week ago when he came. He described it as at the pelvis above the left hip. Let me show you here in this part, where you can't tell exactly which muscle is infected here. He had to give up this tournament. That was the Southern German competition because of the pain. Normally if he had a little pain, he wouldn't stop this because it's a very big tournament for him. And what he told me when he came, he has a recurring typical shin splints, really bad shin splints with an visual analog scale from 8 to 9 during and after his tournaments for the last 2 years. So we had 2 things to treat in this case. With the ultrasound, we saw at the point of the most pain, we saw an intramuscular hematoma it was then the tensor fasciolate muscle. And after the first, we had 3 treatments, and after the first treatment, we had to start with 1.4 bar, which is not much. It was very painful. We also did the cooling, of course, and we also worked on the shin splints. You see here 0.54 bar is really not much, but it was so painful that we couldn't go higher with the first treatment. But it was very impressive. After 4 days, we could go on 2.5 bar here at his at the muscle at the hips, at his left hip. And for the shin splints, we could reach 1.1 bar and 1.2 bar for the second treatment, after 1 treatment. And the third treatment was with 2.7 bar on the muscle and 1.4 to 1.6 on the other side for the shin splints, and no pain anymore on both areas. And he was back to full training, and that was the result. That was the Bavarian U16, means all young people under 16. He's a young 15-year-old, so he's 1 year younger than all the other participants here. And he won the first place 2 times and the second place once in this Bavarian championship, and this was 2 weeks after his injury and with his shin splints. So very, very important. You can have unbelievable fast results for your sportsmen, especially in muscle and tendinopathy problems. Yeah, and he told me I'm allowed to show you his name. Okay. This case is years and years ago. It was a player of Bayern Munich, Colombia national team player, James Rodriguez. I think a lot of you will know him. He had an injury during a normal league match 7 days ago. In this time, the physiotherapists told him that, of course, of his very big edema in the muscle and hematoma in the muscle, he was not allowed to do anything on therapy for the next 10 days. He has to keep calm and do nothing. It was terrible for him because a few weeks later, there were the teams, the games of the national teams for the qualification of the World Championship, and with an MRI like this that said a muscle bundle tear type 3 for after Müller-Wohlfahrt with a width of 1.5 centimeters, which is really big. I show you afterward. You cannot stop doing therapy because how do you explain it to a sportsman like this? Then we started therapy 7 days after the trauma, because for the first 7 days they didn't do anything more than a little bit of lymphatic drainage and a little bit of passive physiotherapy. And we started, in this case, of course, intensive, means radial and focused and every day. And I show you the pictures. And what is very, very important, the clinical examination ultrasound is, for me, during this treatment, the most important technical diagnosis stuff that I need and devices that I need, because the MRI is always delayed. So don't only hang on an MRI, keep to the ultrasound. It's much better. I show you that now. This is the muscle injury here. You can see it over here, 1.5 centimeters. Here it says 1.5 centimeters with a lot of hematoma in there. 2 days after the injury, with, of course, the break ice compression and raising scheme. After 7 days, it was like this. And then we started No, sorry, this is day 9. So we did 2 treatments with Shockwave. He was pain-free after this. Before that, he had a lot of pain. After 2 days with Shockwave, he was pain-free. And this is the MRI after 9 days. So now we go on with our Shockwave therapy. This is day 16, means 7 days later. He is after 2 weeks of treatment, so 21 days from the trauma. It's now 2 weeks of our treatment. He's at a running speed of 80%. This is the MRI on this 4 days before, where you see, still the hematoma in there. You still see the leg here. That's all there, of course. But if you see what he's doing without any pain, running speed 80%, no issues during the running, stair training, okay, then after 28 days, means 3 weeks of treatment, he's doing his first sprinting tests, ball exercises and long passes as a football player. And this is the MRI that again says, oh, there's still here an edema and still some hematoma. If you look at this, you would never think of having this guy on a football field and playing for his national team. But the result after 4 weeks of treatment means on day 35 post-trauma was a 90-minute match in his national team. He scored 1 goal. He was the player of the match and the player of his team. He had no issues afterwards. And with this goal that he scored, Colombia could go to the World Championship the next year. And the funny thing is that the guy bought his own device and is treated every 2nd and 3rd day on his muscle problems that he never had again after this treatment. And when he got the device, he told us that he had a lot of muscle problems the years before, and now years after that we know that he had no muscle problems anymore. This is one of our players from Augsburg who had a very strong muscle hardening before a match. It was really impressive. He came in from the medical staff room from the warm-up, and he told us that he cannot play at all because his leg is very, very hard. His gastrocnemius muscle was very hard, it's right. And he was very afraid of having a severe muscle injury if he goes on. You see it here. What we found out was purple and massive string-like myelinosis in a small part of his right gastrocnemius muscle. He was painful. It was painful when he had to strengthen this muscle. He had less strength in the muscle when we tried it, and but there was no gap, and the ultrasound said no injury at all. So we started the therapy immediately because it was 20 or 30 minutes before the match, with 3.0 to 3.5 bar, with a big applicator and the highest frequency we have. After 5,000 impulses, it was immediately much better. And he went on with the warm-up, and after the warm-up in the last few minutes before the match, we did 1,500 impulses again. And after that, he played 96 minutes without any problem. It was a very intensive match. For us, it was very important because it was the last home victory that we needed to stay in the league. This is just to show how we do this. In this case, always the big applicator, because we want not only to get this small part of myelinosis, but all the other muscle area around it. And you see, we use a lot of pressure. That's why we also want to feel where the problem is and where the biggest pain for the patient is. And then we go through the muscle for about, in this case, for such an area, for about 5,000 to 7,000 impulses. Here is a tibial bone marrow edema, which was a very extraordinary story, because the guy, he's a 26-year-old football player of the 3rd league in Germany. He had pain in his knee without instability since he had a little movement in an indoor tournament. Not really bad, but he was suffering from the pain all the time. And the abstinence from his sport, physiotherapy, all the medication and all that he had, ultrasound didn't make an improvement. That's why he had an MRI 2 months later, because first of all, everybody thought that this is not severe, so we don't need an MRI. Then they saw a bone marrow edema at the attachment of the anterior cruciate ligament, means that he had a little tear of the anterior cruciate ligament exactly at the beginning of the ligament, at the eminentia intercondylaris, with no evidence of a rupture. That was very important. But all that they did afterwards increased the pain. It was not going away. It always came back, and then it got worse and worse. And sorry, there it is. And then we had a completely stable knee, but the drawer test hurted him. The patella had no pathology. So this is the MRI. You see the bone marrow edema. So we treated exactly this point, radial and in this case focused, of course, because you can reach this point very, very good. We were always targeting on the bone where the bone marrow edema took place, of course. After 3 shockwave therapy sessions, he had no pain in everyday life. Before that, he could walk properly. We could do 2.7 bar and intensity of 4 by the focused device. And we let him start cycling in cross trainer again. The MRI check after 5 shockwaves was like this. Nearly no bone marrow edema anymore. For us, this was great because I have to go back. Because now we could do other things like insoles and start running and physiotherapy like normally in his football training, and special strength training again to get his knee more stabilized. And he had no issues all the time and was back on the field at the 5th of July, means 2 months later. He was suffering for more than 4 months before, and 2 months later, he was back on the field. Fractures, because everybody says don't work on fractures, especially don't work on fractures where metal is involved. This is absolutely nonsense. We do this nearly, I would say, every week, that we have players or not even sportsmen, even normal patients with fractures with or without metal in it, and we use it on the metal, without metal. We use it for how do you say, for giving the bone a little bit more, as for example the growth factors of the bone and the osteoblasts, a little bit more power to work faster. That's all that we want to reach. In this case, it's a professional football player from our team in Augsburg. In 2018, he had as you know, a Jones fracture, means this metatarsal number 5 fracture on his right foot. Here is before the operation, this is after the operation. And then we really work hard on it. The first day, it's just cooling and waiting to get the pain a little bit better. The second and third day after the operation, we start Shockwave with the big applicator, because we only want to do lymphatic drainage, not working on the bone with pain, but doing lymphatic drainage. And on day 4, we call it then full contact on the fracture with the big applicator. At day 11, we started with the smaller applicator to get the point a little bit better. I would always ask if we can do also the treatment with the focus device. Yes, you can, but you have to put the smallest applicator, means I think 5 millimeters on it. Then you can try to reach it. In most of the cases, it's at this time a little bit too painful for the patient. That's why we work with the radial one, and you can also do all the treatment with the radial one. It's no problem. It even works nearly the same. Here's the control X-ray after 4 weeks. You see no problem with the metal. This is the control X-ray after 6 weeks. Looks much better. And The player started team training after 11 weeks, and the first game he did after 13 weeks. I think this is really a good time. And we work on these guys afterwards for the next 6 months, once a week, if it's possible. I mean, we have the possibility every day with these guys. So if you work on them once a week to fix the the bones, a nice treatment for them, because it makes the training easier and makes the pain that they have when they get into full load much easier, and so they are faster and happy with the result. This is another, I show you 2 or 3 of them. This is another one after the X-ray after the operation, the X-ray after 6 weeks of shockwave therapy, perfect result. Here are both of them. And what I want to show you is we have a return to competition after 77 days and 72 days, which is perfect. 11 weeks and 10.5 weeks is perfect for something like that. These are the return to activity, return to sports, and return to competition of 3 cases that we had. You see 75, 72, 77 days compared with Mr. Neymar from PSG, who needed 94 days, and one of the best known goalkeepers in the world from Bavaria, Manuel Neuer. This is not a good example, but it's funny to see how fast we were with our young players and in Germany compared with Mr. Neymar from PSG, who has every possibility, and Manuel Neuer has also every possibility. So I think this result is very, very good. This is my last case. This is a pro-American football player, one of the best in the world, I think. He was suffering after a distortion of his ankle joint, suffering from a 2 ligament rupture, which was operated in America. I know his team doctor, Dr. Josh Sandel, because I had the possibility to meet him, or he came to my office because he wanted to learn something about shockwave therapy. He's one of the best known orthopedics in America, and he's the team doctor of the Minnesota Vikings. Really impressive man. And he called me and said, I have one of my players, perfect operation, but he cannot go into his running speed now after 6 weeks. We want to have him get up faster and get the training load increased faster. He's coming to Germany to visit some guys from his German part of the family. Can you work on him two times in this week when he's in Germany? We don't want to have him doing nothing in this time because he has problems. And then we said, of course, he can come. It's no problem. After this call, we saw him. The ankle joint was nearly pain-free, but he had pain in his ventral and lateral thigh, which is very important because this was his biggest problem. He had significant pain in the sacroiliac joint. The right iliopsoas muscle was, under provocation, was painful, and the greater internal rotation of the right leg was something that you could see because his right leg came. His right foot stood like this, and it should normally be like this. And that was the first finding that we had. Then he was treated 2 times. The first time when he landed in Frankfurt, he went to Mainz, the next city, where one of our best friends, Steffen Tröster, is the physiotherapist of the first league team of Mainz 05 in Germany. He is also very well known as a DuoClast user and shockwave therapist and a great physiotherapist. And he worked on a guy at the day when he landed, and then he came to me I think 3 or 4 days later, and we worked on his foot, of course, the upper ankle joint, the lower leg, because he had a swelling in his joint, not because of the operation, I think, because he was completely pain-free in this joint, but because of his tractus or iliopsoas syndrome, iliotract syndrome, sorry, that he had for the last 2 weeks, I think. Because of the foot, he went into this iliotractal syndrome, and that's why we worked on we call it tractus, it's the iliotibial tract, at his ventral and lateral thigh. We worked on his ilius muscle. I want to show you after the cases. My model is here waiting for this. I want to show you. You can work on the ilius muscle inside there if you put the right applicator on, and you get a losing of the hardening of this muscle, and then the hip joint and the whole thigh can relax much better, and that's what we did. And after this, and then you can do chiropractic and something like that much easier. We did all this, and after that we had no problems anymore after the treatment. Directly after the treatment, the upper ankle joint and the lower leg was no problem anymore. The lower leg had no swelling. He had the internal rotation. That was one big problem of his whole leg. Went away. The high knee running, which is normally when they have an internal rotation, not on both sides the same, was again the same. The tension in this muscle area went away, and he had no problems and no pain at his thigh. And then he went back to America, and 2 days later I got the message that he had no more issues 2 days after that, and could start his running training and easy increase the load over the next few days. And he was, I think 6 weeks later, he was still back on the field. And this is very funny because this is a friend of mine. He's a German football player. This is the German doctor, and this is the American football player and his father. So if you need a doctor, okay, come to us to Germany. If you need a football player, go to America. Okay, thank you for your attention. I'm waiting for your questions. I hope you have a lot of questions that we can discuss a lot. And if you want to see something, Tobias is here. He's a medical student, nearly a doctor, half a year, then he's finished with his studies. And we would be pleased to show you something. Tell us what you want to see.
Thank you, Peter. That was a great presentation, as usual.
Thanks.
We have a question from Ferdinand regarding the case about lymphedema. His question is, where I came from the case of lymphedema due to filarial infection is still prevalent. Is it safe and effective to perform shockwave on such patients after or during the therapeutic antifilarial medications performed? Thank you, Nicholas.
Filarial. This is, I don't know this word, antifilarial. What do you mean by that?
Filarial infection.
Infection. Is it meant for the edema or is it meant for the wound case? Because the edema case, there was only the little infection in at the knee.
I think
normally it's called. We can do the whole stuff with edema and wound. Normally, everybody tells you not to work on inflamed tissue and something like that. In this case of the wound, I had the great background that I could send him to the hospital in a few minutes if I wanted that, and we had two different antibiotics working on this wound. So I think that was not so difficult to work with on this, because what should happen? It was a terrible diagnosis. It was a terrible area where we had to work. We couldn't get it worse, I think. And it worked so fast and so good. And the guy told me after every treatment, okay, this wound is now working. I really feel it, how it is working. And the necrosis came up and I could do this necrosectomy without any problem. So there was no problem to work on such a wound. But you have to see wounds like this, you have to see every case on its own. Maybe that your feeling tells you, no, this is too much for me. Maybe there is a bone under it. You can have a inflammation of the bone or something. Then if you're not sure, don't start Shockwave. Try other things that you know that they work. But in this case, for the muscle that I wanted to hold and the muscle that I wanted to have, I think this is no problem to start. There's that's very good. Thank you very much.
Filarial infection. I think it's caused by a parasite.
Okay, thanks. Oh, sorry. This is something I heard in my studies years before, right? This is little worms. Okay, sorry. We don't have this in Germany so often, so that's why I didn't think of this. I'm not quite sure if you can do it. I'm not quite sure what happens to this little worms. Maybe that you kill them by a shockwave, I don't know. But for the lymphatic drainage, I think you can do that if it makes it
help to drain the.
Worse. No, I don't know.
Not sure.
Well, normally you can treat every kind of lymph edema without any problem. But in this case, I don't know what the worms will do. No idea. But a good question to Professor Schmitz. I think I will find it out. You can ask me on. You can have my internet address from MC and ask me via email, and I will find out. This is very interesting. Okay. I think.
I'll send, because he works. Christoph works with worms as well.
But in a slight different way.
But in a different way.
But this is very important. This is for me. It's very
interesting.
I will find out.
And I'm not sure we had that kind of question in previous webinars. So interesting.
No, never. That's why.
So we'll come back to you, Ferdinand. Thank you for that.
That's very interesting. Thank you very much.
Yeah. And we had a question, about corona, about shockwave for the chest. I recommend you to watch the previous webinar dedicated on upper limbs, because we discussed about it, because today it's more dedicated to lower limbs. Mm-hmm. So
what is the question about the upper limbs? I can't see it here.
Oh no, it was in the chat. Somebody asked about corona therapy, shockwaves, use of shockwaves for the chest, but as this session is dedicated on lower limbs, we will focus more on lower limbs, especially if we have this.
If somebody has but this is a very important issue, I think. If somebody has a question to the corona treatment of the chest, please send me an email. I send you everything that I have. It's no problem. I send you a video how we do that and so on. It's in German, but you can see what we do. And maybe we'll do one in English the next weeks. No problem. I send you everything I have, because I think this is a very important kind of treatment, and it works as we see the last weeks and months. It really works, and I'm very pleased if somebody tries this on other people, because they will really have a big advantage.
Even if it's an off-label indication, I think it's good to share it. So we will keep you informed again.
We have a second question here. How about lymphedema and malignancy? That's what I wanted to say. We are working a lot of with, for example, women with carcinoma of the breast. They have the swelling in the arms, and so we're working a lot with a lot of them, and it works perfectly. We have no problems at all. In this case that you see here, we are going over the tumor. I'm quite sure that you cannot do any harm to the tumor, because if I didn't do any harm to the tumor in this case and all the cases I had before, I'm quite sure that it's not possible. But you have to talk to the patient, because it's off-label. It's absolutely known as a contraindication, not because somebody knows that it is bad, but nobody did studies on it. So of course it is a contraindication at the moment, but I hope as many cases that we can bring up now, that we can in a few months or years tell the people it is safe to work with shockwave on malignancy tissue, and do something against the lymphedema. We don't want to work on the tumor. it's very, very important. I don't want to work on the tumor. I want to work on the lymphedema because this brings life quality back to the people. Especially, for example, the breast cancer ladies have arms like this. And if you work with them for 3 or 4 weeks, it's half of this. And then they can go on a working and use their arm and so on.
Yeah, thanks for sharing. Yeah, it's important for tumor not to work on.
And a good question, because of course you see a lot of cases here that are normally, I would say, contraindicated or off-label, but you see it works. But you always have to talk. Yeah, you have to talk to the patient. In most of these cases, the patients came up to me and said, "Can you please do that?" And I said, "It's normally not allowed." And they said, "Doesn't matter. I understand everything." And then you can start.
Yeah. I think we have no other questions so far.
Does somebody want to see
maybe
any treatment or something?
Anything? Have you treated? I have a question myself. Have you treated with Shockwave the psoas tendon?
That's tricky.
That's a tricky one.
Yeah, you can, but we can show if you want. We can treat the end of the only the psoas tendon at the end. Yeah, you can treat it. But the psoas muscle is not possible because you are not allowed to go into the stomach to use Shockwave because of yes, you know, of the air-filled tissue, and that's not possible. But you can, if you work on the ilius muscle and they both tendons come together. In this part, you can work, I think, very, very well. And you can also work on the patient, first of all, on the muscle of the ilius, then the tendon, and then go into a stretching position and work on the muscle and at the tendon. And that is something that brings up unbelievable results. If the guy couldn't use his hip flexors before and had this internal rotation of his leg, if you work like this, it's sometimes like foot like this, like this. This is really impressive, but we can show if you want. It's absolutely no problem. Tobias is in his starting position. So wait, I turn around.
Maybe you can start the hands.
Yeah, we have still some participants, so I think we can do that. This is Tobias. Losing his mobile.
Hi again.
Okay.
I think you need to stop the presentation so people can see in full screen. Yeah.
Of course. Wait. Can you see it again? No?
No, not yet.
Wait a second. Your screen sharing with now.
Now it works.
Now you can see me, but that's not important. So, you see Tobias well. Okay, you tell me if it's not possible to see.
It's fine. It's fine. The angle is good. Perfect. No?
Okay. I'll show you the treatment without using it because it's too loud. We cannot explain it anymore.
Okay.
This is the big applicator of the device. You can also use, in case of these tendons, also use the long one, which is perfectly for that because you can go here into the pelvic bone and you put the device, can you see that? In the position to the pelvic bone, so there is no air-filled tissue under it. And if you put it like this, wait, I'll show you. Good Swiss engineering, sorry. Okay. You put it like this and you reach the complete iliac muscle. If you go down to the end of the iliac muscle, you get into the tendon region here. And now if you come here into the tendon region, the psoas comes down.
Yeah.
Now you reach both of them. And if you know where they are at their end, at the bone, you can go with the tendon to the end of the bone where the anterior-posterior normally take place. And then you can go, if you have loosened the strength in the hardening in there, you can go to the other hip flexors here and go on like this. But for them and the whole muscle, I would take the big applicator again.
Big one.
Yeah, big one, because you reach a bigger area. Just for the iliac muscle, this is really, really a great device, a great applicator. And then and that's the other one. If you, this one is on the other side. If you try to force this, then put your patient like this.
Yeah.
Just let him.
You put in tension.
Yeah, stretching tension on it, and do exactly the same. Get in there, do the iliac muscle, get into the tendon, and then do all the same again. And then exactly the same on this side, because after treating him in normal position, this is all relaxing and getting better. Then you can, I would say, get the next level or the next step, stretch it, do the same again, and then they stand up and say, whoa, what happened to this? Okay?
Okay, so you would do 3 treatments at least?
At least 3,
at least.
For this big problem of the iliotibial tract syndrome, you sometimes have 8, 10, or maybe 12 treatments, because this is something that I have patients that are suffering for 7, 8 years with this problem, because nobody could diagnose. So we have patients who had operations on the hips and the knees, and the problem was always this iliotibial tract syndrome. So if they have this for years, it's very, very difficult.
Okay.
Yeah,
thank you for sharing.
They come with internal rotation like this. You cannot just see his foot. He can show you. Mate. Normally, you have the position like this. Yeah, that's the position we need when we relax. But they come with even like this. And if you understand how much tension you have in this for years, it's also in their head. They go, if you tell them please relax, it's not possible. They go to bed and they still have the feet like this. And you have to tell them how to relax, and that's why we have to work on them sometimes 8 or 10 times.
Okay, interesting. Thank you.
We have these ankle problems. What is also very interesting is the arthrosis of the ankle joint. We can see that. Because this is very easy to treat. You go from ventral into the ankle joint and put. I do this with the applicator, and only put the pressure in there until the guy tells you, okay, now the pain is getting better. Then you step up a little bit, do this 1, 2, or 3 times until you reach about, I would say, 2.0 to 2.5 bar. This is a great result. Then you can go on the back side, where you also can treat the tendons here, the Achilles tendon, the tibialis posterior tendon, and the Fibular tendon back here, and you can also, because you have you come about 4 to 5 centimeters deep, you can from this point, and this point reach the whole joint. Every problem that you have from the arthrosis will be treated, and this is really impressive. People suffering from ankle joint arthrosis for years and years are much better, about 80% better after 3 treatments. And then they come, normally in my office, they come every 6 to 8 weeks, and you can keep this. And that's really great. I have younger and older people suffering from this, that after years and years coming, we treat them, and after 3 treatments, they can go for running, for example, what they didn't do for years because they couldn't step on the foot. And that's for me, very important, because you have a lot of guys suffering from this, as last time with the hands. You have some diagnoses that are so important for me, that all of the guys here in the webinar hear that you can help so many people with so easy things in a few weeks. Please try it. It's really great. It's the same with the arthrosis of the knee. I can also show this. It's the same, and we have a lot of studies that prove that working on the knee and the arthrosis of the knee is absolutely safe with Shockwave, and absolutely successful. So really try it. It is great. Ja, lassen wir das so stehen. And it's easy too. If you put the knee like this, and you go here next to the patellar tendon, you have 2 soft spots. And if you work in a position into the knee from this soft spots, you reach nearly everything in the knee, and you reach the capsular, you reach all the cartilage in the bone, in the knee. You reach, of course, the bone in the knee, you reach the crucial ligaments and so on. So you can work on everything in the knee with 2 points, and of course from the back, because this is very easy. There's nothing, no hard tissue. You have no problem with the vessels. You cannot put any harm or do any harm to them. So don't be afraid. Try it. Another thing is, if you work from the backside of the knee, there are the tendons of the gastrocnemius and the muscles of the thigh coming down and up. And in this part, especially with people with an arthrosis in the knee, they are sometimes shortened. It's like this, and they have a lot of pain when they try to stretch it, and they cannot walk properly because they cannot stretch it when they step on it. Then work on these tendons really with 2.0, 2.5, maybe 3 bar, because this is not so painful. But you can here use all the anti-inflammatory effect of the Shockwave, and the effect that the muscle hardening and the tendon tension goes away in a few minutes. If you work 3, 4, or 5 minutes here in the back of the knee, you can give them free. And you can work, of course, on all the other parts that you reach better from the back. And it's really easy. Another thing, for example, is what we do when there is a position like this, because the tendons are very short. I had the same problem a few days ago with someone who had an operation in the knee, and after this operation he was not allowed to stretch it, and then the knee was like this. And then we first started in this position, then we hold in this position, so we had to stretch it a little bit, and went on. Is the same thinking that we had with the stretching of the ilius muscle, and then at the end we also treated him like this, so like an overstretching, and then we use Shockwave. And this is really, it's the same as it's the same as we had last time with the frozen shoulder. If you put pressure on the frozen shoulder and get the abduction better, you can work with Shockwave, and you have sometimes 10 to 15 degrees in one treatment. So don't be shy. Touch your patient.
Don't be shy. Yes, don't be shy. Talking about the knee and the tibia, we have a question from an attendee asking if shockwave therapy is applicable for paranthering bursitis. If yes, where should we perform it? On the bursa itself or the surrounding structures?
Yeah, perfect question. Always the point and the surrounding structures, always. It doesn't matter, and it doesn't matter where it is. For example, if it's the fibula or the pes anserinus or something, as you said here, it doesn't matter. Wherever you find a point that is most painful, think about, is it where does it come from? Is it the enthesiopathy that is the background? Then go with all the tendons that come from there. The pes anserinus is a point where more muscles are set in. So go with these muscles and ask your patient, is this still painful? Because you always have to treat all the tissue that is also painful to the pes anserinus, for example. And all the muscles that come in this point are important, and all the muscles that work against it. Because if you have for an extensor, you have a problem, you always have a problem with the flexor too, because he has to work in a different way. So that's what we normally do. We work on the whole muscle chains, and we also look at the antagonist. Very good.
Thank you, Tobias. Thank you.
No, perfect. So if you have this problem with the pes anserinus, which is a big problem, start on this point and then go with all the muscles that start from the pes anserinus.
Okay, perfect. Thank you. Thank you for sharing all this. We already, we are coming to the end of the webinar. Any additional questions, participants? Please feel free. In any case, if you do not ask your questions, please you can send us your questions by email.
Yes.
So what do you think? Well, I think we can end this webinar if nobody else has an additional question. So thank you for your participation. That was always that is always a great to share with you. Peter, thank you, and thank you for bringing your patient, who was very compliant.
Yeah.
We will see you next time online on the 23rd of November for a GDT practical session this time, guided DuoClast therapy session. Otherwise, you can follow us on our Facebook page and on the videos page. Also, you have all the webinars available, and we will send you the password to access the replays. Thank you again, Peter, for your expertise. Thank you again. Thank you, Tobias, and we'll see you next time online. Thank you, everyone. Thank you
for taking part. It was great.
Bye-bye.
Bye.
Take care, all of you. Bye-bye.